So good afternoon, PCR Online. I'm here with Dr. Hans-Josef Feistritzer. We're going to discuss the SOLVE-TAVI trial for TCT Connect. Welcome, Doctor.
Hello, thank you, and thank you for the invitation.
So we're going to go right ahead and dive into this interview. So this was a large multi-center randomized head-to-head comparison of self-expanding and balloon-expandable valves. Could you briefly describe the study design, which was, unique, 2x2 factorial, and it was open label?
Yes, thank you for the invitation. Yes, the SOLVE-TAVI trial was an open-label multi-center trial conducted at 7 sites in Germany. And the study chair, Professor Holger Thiele from Leipzig, chose a 2x2 factorial design for this trial. On the one hand, in more than 440 patients, on the one hand, the newer generation self-expandable Evolut R valve was compared to the balloon-expandable SAPIEN 3 valve. This was the first arm of this trial. And in the second arm, general anesthesia was compared to local anesthesia with conscious sedation. Yes, and the primary endpoint the primary endpoints, which were different for the two strategies, were combined endpoints at 30 days. Yes, and these data are already published.
So what were the pre-specified subgroup for the analysis of this study?
Yes, there were a number of subgroups which were analyzed. On the one hand, there were sub-analysis for sex, there were sub-analysis for older and younger patients where the cutoff was set at 80 years. There were a subgroup analysis for the presence or absence of coronary artery disease. There were subgroup analysis for the presence of chronic kidney disease, for presence or absence of frailty, for a logistic Euroscore higher or lower than 20%. And there were also subgroups for analysis for the BMI. And also, and this is an important point, for the anesthesia type. Yes, on the one hand, for the valve comparison strategy, and in the analysis of the in the analysis of the anesthesia strategy, we also did subgroup analysis for the valve type chosen. Yes. So to summarize, there were a number of subgroup analysis analyzed in our trial. Yes.
So what were the most important results of this trial?
Yes, the most important results of the trial were, as you already know, the primary endpoints at 30 days were equivalent. There was equivalent outcome for the two valve types, and there was also equivalence of local anesthesia compared to general anesthesia at 30 days. And now at the 1-year analysis, we showed similar rates of the primary combined endpoint in the valves comparison strategy at 1 year. And there were no significant differences in the individual components of the combined endpoint, with the exception of stroke rates. And this is an interesting finding because the stroke rates at 1 year were higher with the balloon-expandable valve. Yes, these were the major findings in the valve comparison strategy. Regarding the anesthesia strategy, we could show that also at 1 year follow-up, the local anesthesia with conscious sedation strategy results in similar outcome compared to the conscious sedation group.
So how would you explain the low stroke rates with the self-expanding valves as opposed to the balloon-expandable valves, yet it was equivalent, the rates of PVL or paravalvular leaks and pacemakers was the same between the two valves? Is there any plausible explanation you can think of?
Yes, you're right. The stroke rates, were of course really low in the self-expanding valve group, and previous or prior analysis from large studies and randomized studies and registries showed that the stroke rates using in the self-expanding valve group is a little bit higher, about 3 to 5%. Yes, and in our trial it was 1%. A possible explanation for this finding is that the centers participating in our trial are very experienced using self-expandable valves. This is the most reasonable explanation. Yes. Regarding the equal rates in paravalvular leakage between the balloon-expandable and the self-expandable valve, one possible explanation could be that our study center, our centers more frequently oversize the self-expanding valve, and more frequent or more extensive oversizing of a self-expanding valve potentially results in a lower rates of moderate or severe paravalvular leakage. Another important point of our trial is that the permanent pacemaker rates were relatively high, both in the balloon-expandable valve group, but also in the self-expandable valve group. This is an obvious finding of our trial, and as we know from a number of analysis, is that the implantation depth is an important determinant of the need of permanent pacemakers. Yes, it's we might speculate that our valves, that we implanted our valves a little bit too low, but we plan a number of sub-analysis, echo sub-analysis in our trials, which potentially can answer this question, and we hope that we will have this data soon. Yes.
Yeah, so I think perhaps importantly is that the patient substrates were not very different, explaining the low stroke rate. So it wasn't that they were higher risk patients or, abnormal aortas in the balloon expandable that caused the lower stroke rates in the self-expanding. So I'm making that kind of an assumption. And as you mentioned, it was probably more like center experience in terms of self-expanding valves, use of self-expanding valves. And the other, go ahead.
Yes, we could show that we know from the baseline characteristics that the risk, or the SDS score, the logistic Euro score, and the age and frailty was very similar between both groups in our randomized trial. That's the meaning of a randomized trial, that the baseline characteristics are comparable, and so, in our opinion, this could not be the right explanation for the higher stroke rates with the balloon expandable valve. In my opinion, we showed an extremely low stroke rates with the self-expanding valve group, and potentially the most reasonable explanation, in my opinion, is that our centers have very high experience with the core valve, with the self-expandable core valve, and this fact might result in this extremely low stroke rate in the SOLVE-TAVI trial. That's my opinion.
Yeah, and I'm just wondering about the pacemakers. You had mentioned a slightly lower implantation. You're looking into it. I know more contemporary practice now is higher implants than normal, than what we started with. More people are going through to 90-10 implant, or maybe even higher, 95-5. And in terms of self-expanding, they're using cusp overlay to try to get a more higher implant. Perhaps the enrollment of the SOLVE-TAVI was before the use of these techniques to try to have a higher implant, do you think?
Yes. You're sure? It's a very good question, and the SOLVE-TAVI trial started many years ago, and at the start of the trial, it was clinical practice in many centers that the implantation depth is a little bit lower than it is clinical practice today, and maybe that's the explanation for the high rates of permanent pacemakers in SOLVE-TAVI trial. I think if we would start the trial again today, we would have a much lower pacemaker rate in 3 years when the trial is completed. But maybe that's the major explanation for this finding. Yes.
Yes, I agree with you. And we kind of mentioned it just a few moments ago that the STS score for both groups was at least intermediate to high risk population. Do you think the results of the SOLVE-TAVI can be extended to lower risk populations?
I think that we cannot answer this. We cannot do this, or we cannot expand our results to lower risk population so easily. That's an important thing. We know that the severity of aortic root calcifications and outflow tract calcifications and so on very closely associated with the age of the patients, with the risk scores, the STS score and the logistic Euro score, and it's I think that different valve types might differently work in less severely calcified aortic root, so that we cannot this answer from the SOLVE-TAVI trial. We need randomized trials in low risk, more randomized trials in low risk patients to answer these questions, comparing different and most important newer generation valve types.
And finally, how does this trial differ from some of the other trials comparing different valve types, such as the CHOICE and the REPRISE 3 trials?
That's the CHOICE trial, as you know, was a very early trial. In the CHOICE trial, this was in the early days of TAVI, using the first generation core valve compared to the first generation or the early generation SAPIEN XT valve. That's an important point. That's an important point, so that the results cannot be extrapolated so easily. Another important point is that in the CHOICE trial, device success was the primary endpoint, which was in favor of the balloon-expanding valve, as you know, because of the high rate of paravalvular leakage in the self-expanding valve group, and also the higher need of implantation of a second valve, so on and so on. Yes, that's so the CHOICE trial was a very early trial in the area of TAVI. To the REPRISE 3 trial, it's important to know that the Lotus valve, it's a mechanical expanding valve. It's was compared to, on the one hand, the early generation core valve, and also the newer generation Evolut R valve was grouped, so that we have a trial which used 3 different valves. It's also not so easy to interpret it, in my opinion. And also in the REPRISE 3 trial, on the one hand, a combined safety endpoint at 30 days was analyzed, and also at 1 year, the primary efficacy endpoint was analyzed, so that the results cannot be so easily compared to the results of the SOLVE-TAVI trial, in my opinion.
Well, thank you very much. And just one last question that I'm eager to know your point of view is this: there was a lot of subgroup analyses done on the trial. Any particular ones, especially when you're looking at sex differences? Was there any difference between men and women in your trial, in particular with relation to anesthesia?
In the anesthesia comparison, both anesthesia strategies were equivalent in females as well as in males. That's That's data from the primary analysis. But we plan further analysis regarding sex differences, also regarding the valve comparison strategy, and also in the field of the anesthesia strategy. Such analysis are planned and will be conducted soon.
Thank you very much for your time. And PCR Online, meet us again with the next study. Thank you.
Thank you for invitation. Thank you.